Welcome, everybody, to the Voice of the Coalition. This is the podcast where industry leaders and policymakers meet to discuss the future of insurance, compliance, and ethical marketing practices. I'm Bill DeCourcy, the president of the Insurance Marketing Coalition.
And I'm Chris Michelson, one of the board members of the IMC. In each episode, we dig into the conversations that matter, from how healthcare policy gets shaped, to how regulations evolve, to how coalitions like ours can drive meaningful change for the people that we serve.
Today's episode is a true privilege. We're joined by a guest who has been at the very center of American healthcare and public policy for more than 2 decades, Dr. Tom Price. Welcome, Dr. Price.
Thanks, Bill, so much. And Chris, great to be with you all. It's wonderful to have this opportunity to share a few words and to thank you all for what you do.
Yeah, no, it's our pleasure to have you on this podcast with us. Trust me. A little bit of background on Tom's career, right? So from serving the Georgia State Senate to representing Georgia's 6th district in the U.S. House of Representatives to his appointment as the 23rd United States Secretary of Health and Human Services, Dr. Price has spent his career working to reshape the systems that serve patients and providers across this country. One of the reasons that I've grown to respect Tom over the years is his unwavering dedication to serving the people of this country. That same spirit, right? The service is at the heart of the Insurance Marketing Coalition's mission as well. We both want to give a voice to the most vulnerable communities and advocate with care, concern, and a commitment to doing what is right. Over the last few years, the changes that have been imposed on agents, carriers, and constituents alike have left many gaps and unanswered questions. And today, we have the opportunity to hear from somebody who foresaw much of this happening long before it reached our doorstep, and who continues to lead with clarity and conviction. So Tom, Thank you.
And why does this matter? It matters because in today's conversation, we're going to start by exploring that journey. And it's a fascinating journey. It's from a journey that starts with a practicing orthopedic surgeon to someone who led federal healthcare reform efforts. We're going to talk about the motivation behind his work, his opposition to the Affordable Care Act, and how his policy philosophy has evolved over time.
Let's get into it.
Yeah, let's get into it. Let's talk about this. So welcome. So Dr. Price, I mentioned earlier, you transitioned from a successful orthopedic career into politics. I think all of us are curious. What first motivated you to run for the Georgia State Senate back in 1996, I believe?
Well, Bill, thanks so much. And Chris, before we jump into that, let me just thank all the folks on this podcast for what you do every single day. One of the challenges that I had as a physician was to make certain that I was doing right by my patient, and every single day that was my mission, is to do what I needed to do to make certain the patient had the best outcome. What you do every single day is to make certain that your customers or your clients, whoever it is, has the best opportunity to have access to the kind of coverage that they want and need for themselves and for their families. So thanks for what you have done. In my entire political career, the insurance industry has been remarkably supportive, the vast majority, remarkably supportive of my efforts to make certain that you could do what you need to do, and physicians and other providers could do what they need to do. So thanks so much. As you mentioned, I spent 25 years practicing orthopedic surgery, loved it, loved taking care of patients, loved the operating room, loved what I was doing. I recognized early on that there was somebody else that was oftentimes in the clinic and in the exam room, and that was whoever the policymakers were. They were making the rules. They were figuring out what it was that I could do for and with my patients. So my wife, who's an anesthesiologist, we kind of got involved in local political activity, and one thing led to another. And in late 95, early 96, I got asked by our sitting state senator to run for her seat. She was in the state senate and decided she wasn't going to run again, and said, you've got to take this seat. I told her she was out of her mind. There was nothing, that was the furthest thing from my mind at that point. As I said, loved taking care of patients, loved what I was doing. I think within an hour, maybe an hour and a half, over a piece of strawberry pie at Shoney's, she had convinced me that I was the only person that could take her position. So she was remarkably persuasive. I ran a race that wasn't supposed to win in 1996 as the state senator won that race. And the rest, as they say, is history. So it wasn't all by design, but it certainly was by passion, certainly was by commitment, certainly was answering that question that I had to answer, which was, can you do more as a public servant for your patients than you can as an individual physician? And I ultimately came down on the side of trying to serve patients and folks across this country as a public servant.
So thinking back to 1996 and where your service could be put to best use, that was a transformational time, or at least there was an attempt to make that a transformational time. And you know, I don't want to betray any of my own personal political feelings here, but that balance you talked about between that third entity that's in the examination room for you, that third entity was trying to open the door even further and bring more people in 1996.
Yeah, without a doubt. And I had gotten involved earlier, 6-8 years earlier, in our state medical society. I've risen up the ranks there, became vice president, I think, of the state medical society. When Hillary Care came along after the 92 election, we as the Georgia State Medical Society, or the Medical Association of Georgia, came out with what we felt were the right solutions as opposed to what Hillary Care was. I don't know whether I was out of the room when it happened or whether I raised my hand, but at some point they said, all right, who wants to go communicate our solution to the people of Georgia? And so I had the opportunity to literally travel around the state of Georgia, get in my car and after seeing patients for a whole day, and drive for 100 or 150 miles, and then talk to a Rotary Club or a Kiwanis Club or a civic group or a church group or anybody that would listen, frankly, about what we felt were the principles of healthcare and why we felt that Hillary Care got it wrong. And through that process, through that engagement and interaction, I found that I enjoyed that. I enjoyed talking to people. I enjoyed sharing my passion for quality healthcare and the imperative of physicians and patients and families to be engaged in the decision making as it related to healthcare. And so that, I think, that kind of piqued my interest from a political standpoint. And then, as you mentioned, 94 was the Republican Revolution. I live on the north side of Atlanta and have since the early 80s. Newt Gingrich was my representative since his election in 1978 to the U.S. House. We became good friends during that process. When he was in the minority, he would speak to anybody before he got in the majority as speaker, and he would challenge folks to get involved and get engaged. And I was one of those individuals just sitting at a cafeteria one day where Newt was speaking and saying, you don't need to improve the score on your golf game. What you need to do is get in the game. You need to get in the real game, in the political game. And that kind of just pierced me. And so 94, the Republicans took the majority in the U.S. House for the first time in nearly 40 years. In Georgia, the Republicans had never held the majority in our state legislature, either certainly not the state Senate, even since Reconstruction. And so when I got elected in 96, I said, well, why not become the majority? If it happened up in DC, why can't it happen right here? And so worked with some folks to try to make that happen. Ultimately, we did. In 2002, we took the majority in the Georgia State Senate, and I was privileged to become the first Republican majority leader in the history of the state. So it was quite a ride.
I imagine it was. No, I'm interested in the beginning of that ride. Just one more question. I think when you talk to a lot of freshman representatives or senators, whether it's at the state or the federal level, it's never what they expect. 6 months in, you interview them and you ask, what's it like? And the word that I keep hearing repeated is surprising. I think that your story has the potential to be a little bit more surprising or maybe even jarring when compared to others, because you went from treating patients to legislating policy. What was that like, and what early lessons did you learn once you were on the ground in the state capitol?
Yeah, it's a great question, because in medicine, I was privileged to be in a profession where when I went into the clinic room or the emergency room or the operating room, I knew that every single person in that room and every single person that I engaged with had the same mission, the same goal with their activity. We're all trying to help the patient, get the patient better, get the patient well, or to treat the patient. In the world of politics, it never dawned on me how different it would be, because half the folks want you to fall flat on your face and fail, and the other half you're not so certain about.
Right.
So it was really an eye opener. I'll never forget in the state Senate, one of the first during my very first session, which would have been the '97 session. We were in the minority. I was young and full of spit and vinegar and energy and enthusiasm about what I thought needed to be done. And I went down to the well in the Georgia State Senate and gave some remarks of speech about whatever it was that was the topic of the day. And I went back to my seat, and I was pretty proud of myself about what I had said. And Senator George Hooks, who I'll never forget, was a wonderful old Southern gentleman. He was a Southern Democrat, so he was a relatively conservative guy, just a peach of a guy. He was as kind and gracious as he could be. And he got up and he said, "Isn't it great now that Dr. Price is here in the Georgia State Senate with us? Comes down and shares his perspective on what needs to be done," whatever he said. But I was pretty puffed up, I said, "Well, there's nothing to this," and it wasn't it couldn't have been more than a week later that I went down again to the well and gave some remark about something. And I went back to my seat again, proud of myself. And George Hooks, the same guy, took the mic and said, "Isn't it awful that Dr. Price comes down to this Georgia State Senate and all he does is rail against what needs to be done for our state, and all he wants to do is look out for physicians and doctors." And I thought, well, this is a different place. So that's those things that they teach you that they teach a number of things. One is that most of the disagreements that came about then, and I don't know that it's the same now, but they came about then, were not personal. Somebody wasn't out to get you. They were trying to advance their position and their cause. And so I never took things personally. I never held a grudge against folks. I think that's one of the most important things in the world of politics. You can't keep fighting the last battle. Your opponent or your enemy today, from a policy or a political standpoint, is going to be your friend and your ally tomorrow. And if you burn all those bridges, which I fear tends to be happening these days, if you burn those bridges, then you never have the opportunity to either make those friends and develop those fellowships and those allies on certain issues, but you also turn the world of politics into something that is just a shirts and skins game, which I find to be abhorrent. I think it doesn't help solve the challenges that we have.
I know Chris has a question, but I just have to say, based on that, where have all the blue dog Democrats gone?
Yeah.
Chris, you have a question?
Yeah. So what you're talking about resonates a lot with what it is today still, right? I mean, it's red, it's blue, it's red, it's blue, and there's no middle ground, it seems like, or that middle ground is ever diluting. When you're in office and you see legislation coming across your desk that you don't like, right? And we'll talk more specifics later, but just generally speaking, how are you blending that balance of knowing you need to have cooperation with getting the point across that you're not for this at all, right? How are you building the trust and leadership in that environment? Because you rose to the top, right? You were the majority leader.
Yeah, and it was an incredible privilege. I think a couple of things that I did. One was that early on, I was counseled by my predecessor, who was the minority whip in the state Senate before I was elected, to learn the rules. Most folks don't know the rules of a chamber. And that's true at the state level. It's also true at the national level. So if you learn the rules, then you know what you can do, what you can't do, and how you can get done what you want or need to get done, which is incredibly important because, as I say, most folks don't take the time to be able to do that or to do that. Second is that I committed to myself in the state Senate and I was able to do this almost all the time, and that was to read every single piece of legislation that was coming across my desk. If it was in the committees that upon which I served, it was introduced there, then I certainly read it. If it was coming to the floor, then I did my very best to read it. If it never came to the floor, then I likely didn't necessarily read it. But I tried to understand what it was that the individual that introduced that was trying to solve, what problem they were trying to solve, and how they went about it, and whether or not they went about it in a way that one, I agreed that there was a problem that needed a solution, because oftentimes bills try to solve something that doesn't need a solution. And two, whether the solution actually was consistent with the principles that I thought were important for representation. And there are all sorts of those, and we can talk about those if you want. But once I got through that, then if I still disagreed with it, then I oftentimes would go to the individual, just sit down and say, privately, not publicly, just sit down and say, what is it that you're trying to do here? If they needed my vote, then I would certainly let them know whether or not I was able to support them. The coin of the realm in the world of politics, at least used to be, was your word. And the last thing you want to do is to lead anybody astray. If you're not going to vote for their legislation, then you got to tell them that you're not going to vote for it. And the reason why. If you are, then you can tell them you can tell them that you're going to support them, and that support oftentimes has different levels of support. Whether it's I'll vote for it, I'll vote for it, and I'll speak for it, I'll vote for it, and I'll work for it. Whatever the issue is. So these are just plain folks. So you just got to treat them with the kind of respect that you would want to be treated with, and that's incredibly important, because again, I think we've gotten kind of offline on how our political engagement.
Well, we've gotten online, right?
Yeah.
we've gotten online, and the internet has given people, the internet has given people computer muscles, and everybody's much stronger behind the scene.
Exactly.
But you said something really interesting that kind of ties into a good segue, right? Being polite even in the face of opposition. And you were an early and vocal critic of the ACA, right? And as it was introduced, you introduced the Empowering Patients First Act, right? Can you walk us through just your motivation and vision behind that policy? What was it about the ACA, right? Specifically, I'll give you specifics. What was it about the ACA that you were like, no, not the right way to do it? This is why empowering patients is the better move. And as a follow-up, how accurate were your predictions looking back now that we're 10, 12 years beyond?
Well, I didn't come to this lightly. The knowledge base on healthcare in Washington is relatively shallow. So there aren't a whole lot of folks, and that's true of a lot of issues. There aren't a whole lot of folks that have any real in-depth knowledge about healthcare, the healthcare system, or how one would fix the healthcare system if you felt that it needed fixing. So I always believed that if I didn't support something that I was adamant about, then I ought to have a better solution. I ought to have a better way to address the challenge. And that was true even before the ACA. So once 2008 came along, I had introduced a lot of different pieces of legislation that addressed the challenges that I thought ought to be addressed, many of them in the area of healthcare. So when the ACA came along, and oh, by the way, I actually have the ACA right here. So this is how awful my life is. I still have the doggone piece of legislation.
Look at that
word.
So, and I read every word of that. But
wow.
So I thought it didn't do us any good as conservatives or as Republicans, my team at that time, to just say no. That you ought not do that. That doesn't make any sense. We ought to say, that doesn't make any sense. Here's why it doesn't make any sense. And if you're really serious about addressing the problem, here's a solution. And that's where the Empowering Patients First Act came about. I had the privilege at the time of being the chair of the Republican Study Committee, which was the conservative group of folks in the House Republican caucus. And so I I just put out the word to all comers. I said, if you want to help me work on a solution to the area of healthcare, then let's start getting together. We saw this train coming down the track, and come up with our alternative. And that's where the Empowering Patients First Act came from. The ACA itself was my suspicion was because it grew off of Hillary Care. Now here's Hillary Care. It's a little bigger. Even has Hillary's signature on it. So,
who's the second signature on that, Dr. Price?
Second signature on there is Ira Magaziner.
Ah.
So he was the staff architect of Hillary Care. And I looked for these the other day after we had our conversation, and I said, I wonder if I can find those doggone things. And there they are. So I haven't thrown them out yet, much to my wife's but the left, the Democrats have been working for decades to get greater control of the healthcare system, for a variety of reasons. If you're altruistic and you're generous in their motivation, and many of them were very sincere in what they thought they were doing. They wanted to get more coverage for folks. They wanted to get more access for folks, and they wanted to lower costs. So accessibility, affordability, and quality stuff that they talked about. And so if you want to give them the benefit of the doubt, then you'd say that's why they did what they did. The problem is what they always fall back to is control of the system from on high. So central decision making, central authority decision making that was at the core of Hillary Care, but also of the ACA. I knew as a physician, and I knew as an individual policymaker for the previous 12 plus years, that if you put government in control of healthcare, then you cannot be responsive to patients, which I thought was one of the principles that we ought to adhere to, because it just doesn't work. Government isn't responsive to individuals. You'll remember that we used to talk about if you want the efficiency and responsiveness of the post office, then vote for the ACA, right? Vote for Obamacare, and everybody understands that, and there really isn't a better way to do it from a governmental standpoint, because they have to control these levers if they're going to control the costs, which is what they wanted to do. And so their goal was to provide President Obama's goal was to provide access to everybody. Remember, he talked about making certain that everybody had access, but he also belied his assurances, which were, if you liked your doctor, you can keep your doctor. If you like your insurance plan, you can keep your insurance plan. Well, we knew that wasn't true. And if you read the doggone bill and you just parsed the words, it was clear that it wasn't true. And so from my perspective, all of the things that we predicted, which was higher costs, not lower costs, decreasing accessibility, because coverage doesn't necessarily mean accessibility if your deductibles and your copays are through the roof. So decreasing accessibility and decreasing affordability for folks, and increasing costs to the federal government. So an increasing federal government control of healthcare. All of those things we warned about and thought would come to pass, and they have. And so the Empowering Patients First Act was an effort to respond and adhere to the principles of healthcare that most everybody has. It's just how we get to reach those principles or fulfill those principles. And they are, yes, affordability. You got to make it so that everybody can afford their coverage, regardless of what their station is in life. Accessibility. You got to have everybody be able to have access to coverage. I believe in universal coverage. I just don't believe that the government ought to be the one providing the universal coverage. The highest quality, and the way that you do that is through a responsive system to patients. So responsiveness, innovation. You got to incentivize innovation. Which is a challenge right now, and I'm happy to talk about that. And then choices. Patients and their families need to be one that decide what kind of coverage they have, who takes care of them, where they're cared for, and the like. So accessibility, affordability, quality, responsiveness, innovation, and choices. Those are the 6 principles that we tried to put into a piece of legislation through the Empowering Patients First Act that would solve so many of the challenges that we have in our healthcare system. And it was the only comprehensive alternative to Obamacare at the time. And I enjoyed being the champion of it, and enjoyed presenting it to folks and having them nod their heads, including in audiences that weren't all the way over to the left where they thought the government ought to control everything.
So, Dr. Price, I'm curious, and I'm going to go a little off script here because, a lot of us, whether it's Labor Day or coming up, the fall holidays like Thanksgiving and Christmas and the like, we're going to be sitting around with our friends and family, and we're going to be having a lot of these discussions, as we often do. What do you say when you're asked, when you're told, okay, the federal budget, a large portion of the federal budget goes towards entitlements like Medicare, so the government is writing the check. Why shouldn't the government have their hands on those levers directly with that central mechanism that Hillary Care advocated for, and the ACA in a lot of ways has accomplished?
Well, it's a great question, and the answer is twofold. One is that when the government controls the cost of something, or what kind of taxpayer money is being spent, it never controls the cost. It always elevates it because of the entitlement mentality. And when you give something to somebody for free, then surprise, surprise, many of them actually like it, even though it may not be which would be the most beneficial for them and for their family. And then secondly, you cannot control the costs or attempt to control the costs without controlling the means of either production or service.
Mm-hmm.
And we know what control of the means of production means. That's not our system at all. And I hope we don't head in that direction. But if the government's controlling the means of production, that's a system that doesn't have the kind of free market choices and free market capitalism that has resulted in the most incredible success that a population has ever seen in the history of mankind. If the government controls the service, then the service then is responsive to the government. It's not responsive to the end user.
Oh, that's a very interesting
of necessity.
Yeah,
necessity. So
incentive structure.
That's why. That's why. I mean, the government the government has a role. Don't get me wrong. Government has a role, and that role ought to be as hands off as possible. To for example, electronic medical record. Government spent 15 years ago, spent $30 billion to enforce electronic medical records in the healthcare system. Made it so that every physician, every provider was mandated to have an electronic medical record. Mm-hmm. And because they were so beneficent, they allowed the providers to get any electronic medical record that they wanted, which sounded good, right? But none of them talk to each other. So you get none of the interoperability that you have to have in order for the system to become more efficient. So the system, they not only wasted $30 billion, they developed a system that doesn't work and is not responsive to the patient. So that's the kind of that you get out of DC. So
that's an incredibly. I mean, I'll tell you, the other day we had a minor health scare in my household, and we have two major hospital chains that are 5 minutes from my house. Yeah. And we made a decision on where we were going because we knew that this person had a record from a previously related thing, right? It wasn't that was the absolute determiner of where we went, which was, I don't want to have to fill out that form again. Right. Unbelievable. That's a great answer.
Well, guys,
great answer.
Guys, the good news is 30 years later, we're now getting TEFCA in 5 months. So it only took them 30 years to figure out how to make the hospital systems talk to each other.
Yeah. And if that
why wouldn't you want them running your healthcare?
If that works out, I'll buy you an ice cream cone. So.
Yeah, exactly. Right. It's going into effect Jan 1 of 2026. It'll work sometime around 2050. My word.
Chris is playing the role of the optimist here. Chris, you had another question.
Look, I think it's just. I think it just is what it is, right? All right. So
let me talk a little bit about, if I may, about what the solutions might look like.
Please.
Because I'm not an individual. I'm a type A surgeon, right? So all I know how to do is to evaluate something, figure out what the options are, and then go fix the doggone thing. And if you don't fix it, then and you evaluate it, scientific method, you keep evaluating it, and until you fix it, you keep trying what you think is gonna help solve it. So there are a couple things that are imperative. One is that we've got to make it so that the individual owns their health coverage regardless of who's paying for it.
Mm.
So that's how you get the government out of the loop. You say, even if the government's paying for it, the individual has to own it. So it's like your 401k plan. When you change your job, you take your 401k with you, right? I mean, that you take your, that ideally, that's what happens because that's yours. Your health insurance ought to be the same thing. So that you own it. And the reason that's important is that the system needs to be responsive to the patient, not to the government. And the only way for it to be responsive to the patient is to have the patient in charge of those things. Second thing that's imperative from a principle standpoint is that health decisions, medical decisions, need to be between patients and their families and physicians or providers. Now there can be guidelines. There has to be some regulation. There has to be some opportunity for individuals to say, yeah, this is a good doc, this is a bad doc, these are the things that you need to do, as opposed to the system right now, which measures every single dot and tittle that everybody does in the healthcare system, which is incredibly expensive, and then doesn't even improve the quality of care that's being provided. So those are the kinds of principal things that we put into the Empowering Patients First Act that would fundamentally change the way healthcare works in this country. That has been that kind of our system that we have right now is a system that we have by default. Somebody's always trying to fix it, add a little, add a bell here or a whistle here or a color here or whatever it is. And it's not a coherent system. The only way I believe to make it a coherent system is to get back to fundamentals, get back to principles, and make sure that the patient is in charge and the patient's decision with the provider is what prevails.
Very good.
So the patients are kind of getting, jerked around back and forth over the last couple of years, right? I'm going to ask you to play Tom Stradamus here. Are these subsidies for the ACA coming back anytime soon? This is a huge question, I know, from our audiences. So much of their marketing, so much of the agent's ability to sell net new policies revolves around these IRA subsidies. You think anything like that's coming back?
I doubt it. Washington's always looking for money, and so when the fact that it wasn't included in the reconciliation it's highly unlikely that the ACA subsidies that were put in place previously are going to come back. Now that doesn't affect the original ACA subsidies,
right.
and those could be attacked as well. But I doubt that the ones that are in place right now that are set to expire at the end of the year are going to come back. The other dirty little secret that's out there, and all of the folks who are on this podcast understand and appreciate this because you know the market well, and that is that because of my generation, the boomers, we're an aging population. We've got 10,000 folks reaching retirement age every single day in this country and will for another 10, 12, 15 years. So the number of folks into Medicare is skewing to increase over the next number of years. And Medicare is actually a fixed cost program. So that the cost the cost shifting that has been available, because oftentimes Medicare doesn't even cover the cost of the provision of care, as you all well know. Medicare, the cost shifting to the private sector through private plans, health plans, is only going to increase, which puts greater burden on not just the national debt, because of the cost of Medicare and Medicaid and Social Security, but it also puts increasing pressure on the private sector in terms of the provision of health insurance because their costs are increasing. They're having to cover the increase in costs in the system, which Medicare isn't covering. So we're reaching crunch time in our health system and in our financial system in this country, and there will come a day when the piper comes calling.
But Tom, Medicare Advantage was supposed to save the government money. How could it possibly not work?
That's right, exactly. But and there is a way to do it, though, I believe, and that is to make value-based purchasing, you've got to make the risk in the right place. So, if in fact the government wants to decrease costs and have this shared risk, you've got to make it so that the folks providing the care have a financial risk. That's fine. It's not the way I would do it, but that's fine if you want to do it. But you also have to make it so that there's a reward on the other side. What the government does now, as they've done through all sorts of different programs, they put the provider at risk, and then when they save money, they take that money back.
Mm-hmm.
Instead of saying, okay, now you can that because you saved that money, you're going to be able to benefit from it. So the incentives aren't aligned in the healthcare system. You all know this well because you live it every single day. But the incentives aren't aligned, and so if the incentives aren't aligned, you'll never get to the solution the way we're doing it right now.
Well, speaking of being able to provide solutions and add our voice, one thing that I won't call it intimidating, but as a new coalition, one thing that I don't want to be pigeonholed as is just another special interest up on the hill, right? And I can say sincerely, having been with this organization since the very beginning and have had the pleasure of associating with people like Chris and many others in the organization that really do look at this, if not fully altruistic, in a way that balances business gain with beneficiary care and ultimately makes decisions that are very much skewed towards making sure a beneficiary has the best experience. Having said that, how can we position ourselves as a trusted partner to the government to go to them and say, we have ideas, we want to contribute to the conversation, rather than being seen as that, that term that I don't like, a special interest?
Yeah, it's an incredibly important question. And first, let me commend the IMC because I read your mission, read the things that brought you into being, and so incredibly important to have ethical and principled leadership and a touchstone for folks to come to in this industry and be able to say, yeah, these are the folks that are doing it the right way, and I want to follow that path. There's always a nexus between an industry and policymakers. This is true at the state level and it's true at the federal level. And that is that your customers, your clients, if you will, the people who desire to utilize your intelligence and your knowledge to develop a plan for themselves that's best for themselves and their families, are the same people that are the politicians and public servants' constituents.
Mm.
So that's the common denominator.
Mm.
So I used to tell docs when docs are awful at lobbying. They're just terrible. They're awful at advocating for their profession, and they have been, just like me. They're relatively independent. Most of them have the best idea that's ever been had. Just ask them, and they'll tell you. And they want to go in and talk about mostly self-centered things, self-interest things. And that's what most folks who came into my office when I was a member of Congress, which I did for 12 plus years, privileged to do. Most folks came in and they couldn't help themselves, right? They always had to talk about why they personally needed X.
Mm.
And I promise you that won't move many folks at all. What will move people is if you make certain that they appreciate and understand that the people that you are fighting for, and you are, the people that you're fighting for are the same people that they represent. And if they want to help their constituents, then this is how they can help them in this arena. And then the mission becomes it's not completely altruistic, but the incentives get aligned.
Mm-hmm.
The incentive of the political the public servant, the person in office, gets aligned with your incentive because you're trying to help the same person. Now, I can hear folks out there right now. They're saying, "Yeah, but they don't care. The politicians don't care, right? They couldn't give a hoot." And sadly, for some, that's true. But for most individuals who go into public service at the state and at the federal level, most of them if you think about how they got to that position, most of them had accomplished something either in their profession, in their community, that brought them to prominence and brought enough people to be able to say, yeah, I want Joe or Sally or Sue or whomever. I want that person representing me. I can't do that or don't want to do that, but I think he or she would do a good job. And so you got to try to figure out how to tell your story in a way that not only makes it clear to them that your customers, your clients, are the same people as their constituents, but also that you're wanting the same thing as they want for their constituents. Because again, most folks who go into public service do so for a reason. If they had to write it down and show it to you, a reason you'd say, well, that makes sense. Now, some people, you can get pretty distorted in that world, and especially that circus up in DC. But that doesn't mean that they somewhere back in their head can't remember what it was like when they first ran.
Well, there is the common ground that we need to, that nexus that you described. Chris, did you have
yeah, so just thinking on what you just said, is it really just be boots on ground and go after local representation? And does it make sense to start from the bottom and work your way to the top, or does it make sense to try to make noise at the top and hope it trickles down? Like, should we be going after district leaders, or should we be going and advocating like on the Hill directly?
Yeah, a couple things. One, you all have day jobs, and
yes,
it's tough. It's tough to do this, and that's why it's important for the coalition to come together. That's why it's important for every single person who's on this podcast that's a member of IMC to remain a member and advocate for others to become members, because your voice is stronger when it has more people behind it. Second, there's a minor leagues, if you will. There's a training ground for national leaders, and it's usually local and state politics. Not always, but it's usually local and state politics, which is why I implore people to get involved at the local level. I promise you, I ran for office first in 1996. I remember the first person that wrote me a check. To this day, I remember the first person that wrote me a check and said, "I'll support you." And so early support for somebody at the state level is incredibly important. And your goal in all of this is just to simply develop relationships. If you can become a friend to that person who's your local state senator and state representative, that's important. And it's so much easier at the state level than it is federally. And oftentimes those are the individuals that will rise on up. And so I encourage you to do that. Same thing is true in Washington. You can meet folks. The best place to meet people who are representatives or senators in DC is in the district, is at home. It's not in Washington. It's important to go to Washington on those fly-ins, but the best place to meet them is at home, because Washington is a zoo. And whoever's up there, the representative or the senator, they're supposed to be in 8 or 10 different places at the same time. And so it's hard to give undivided attention to an individual who's coming in with a problem or a challenge, not because they don't want to, but just because of the nature of the job. So meeting them at home is incredibly important. The other thing that I would implore folks to appreciate, and this is oftentimes not well understood, and that is that, especially in DC, there's a staff person who is in charge of the issues that you care about. That staff person oftentimes knows more about the issues that you care about than the member of Congress or the United States senator. That staff person is the person that the senator or representative is going to talk to when these issues come to the fore, come up. And so you're developing a relationship with that staff person is as important, if not more important, than developing a relationship with the member and him or herself, because they're the people who are going to affect the counsel, if you will, that will be given to the member of Congress or senator.
It's kind of funny as you're saying this, right? Like, so much of what you're saying translates back to business in a lot of ways, right? Sales is the exact same way. You've just got to have that like relentless pursuit. So I guess from that tie in, we've got, I think, about 15 minutes left. I know Bill has another question as well, and then we want to try to get a couple questions from the audience. I feel like we'd all be kicking ourselves if we didn't ask the question. Tom, what's coming next, man? What do you think the next big hammer to drop, on our industry is going to be? Whether it's ACA, Medicare, what are you hearing? What should we look out for?
Well, to state the obvious, we are living in very uncertain times. So it's tough to predict anything, how anybody's going to respond to anything. And it's also, from my perspective, it's a less deliberative time than we've had in the past. Now, sometimes we haven't had a lot of conversation about issues, policy issues, but right now, my sense is that there are very few people in DC who are meeting on the policy side and saying, let's work this out. It's a lot of, and this is true on both sides of the aisle. It's a lot of instruction coming from on high. This is what we're going to do. This is the play call. Get in line. This is your job, which is I think troubling from a solution standpoint. But it also means that the responsibility that one has to engage at the state level becomes that much more important, because at the state level, in the vast majority of states, there's still policy discussions going on because you don't have the kind of staffs that you have or the kind of budget that you have up in DC. So the state level becomes that much more important. And candidly, the bigger structure is, yes, it's defined by DC. But oftentimes the nuts and bolts, the things that either improve your day or make your day a disaster, are coming from the state level as well. And so engaging at that level is incredibly important. We are, I think I mentioned that at some point we're going to have to pay the piper, and we will on Medicare. You can't continue the way we're doing. I think the trustees came out, and I think that Medicare now goes broke, if you will, in 27 or 28. I mean, it's near term. So something's going to have to change. And I believe what will change, if past is prologue, what will change is that Washington will dictate more about what has to happen. And they won't say that and won't sell it that way, but they'll dictate more about what has to happen, which confines or restricts what your industry oftentimes is able to do. When in fact, what they ought to do is provide greater flexibility in the system, which over time, if you allowed it to happen, would allow for greater control of costs, because of the kinds of things that you can put in place that will actually control costs, as opposed to just limit what folks are able to do.
Very good. Dr. Price, I just have one last question, and it's not specifically related to policy, but I think it's something that whenever you have an opportunity to ask somebody who's had your career and your experience this question, you should probably take advantage of it. What is it like being HHS secretary? What's it like being a member of the president's cabinet? I'm fascinated by your perspective on what that experience was.
It was probably the greatest privilege that I've ever had. It felt, when I was asked to be HHS secretary, it felt like the culmination of a life's work. Right? I spent 25 plus years practicing medicine, practicing orthopedic surgery. Put in the time and the effort and the diligence to gain an appreciation for the system of our healthcare, which is really systems. It's not a system, but it's systems. And had a notion about what we could do to help more people in this country as it relates to healthcare. So incredible privilege. 80,000 dedicated employees at HHS at that time. Biggest budget, the biggest budget of any of the departments. Was $1.3 trillion when I was there. The vast majority of that Medicare and Medicaid, but huge amounts of resources going out. So it was an incredible privilege. In terms of the people in that cabinet, they're great folks. They're great folks. When I was first nominated, I talked to a number of previous HHS secretaries to try to get a sense about what it was that I was about to enter if I was confirmed, or when I was confirmed. and almost to a person, they said, you just have to appreciate that you may think you're your own boss, but in fact you're not.
Mm.
The Office of Management and Budget, OMB, and DPC, Domestic Policy Council, both run out of the White House, and appropriately, are the folks that you have to run everything by. And so it would we had just a great opportunity. I was only the third. I was the 23rd HHS secretary, only the third physician. Two other docs before me. Most folks are not physicians who come into that position. I was the first individual that I'm aware of to outline clinical priorities at the department, and I outlined priorities that I thought were 3 clinical priorities that I thought were incredibly important and were weighing down the nation. And they were the opioid crisis, severe mental illness, and childhood obesity. All 3 of those we were losing on. I think we're still losing on all 3, and it's because I don't think we put the kind of focus and attention and resources to come to bear to solve those challenges. But a lot of dedicated people. It was an incredible honor. I wouldn't have traded it for anything. So it was a great privilege.
Well, thank you, Dr. Price. We've got some questions, as Chris mentioned, from the audience. I'm going to go ahead and put those up on screen here. Sean Green asks, what is, Dr. Price, the most efficient way to achieve 100% access when it comes to healthcare?
Well, if you're meaning coverage, then the Empowering Patients First Act had the solution, and that is that if you're able to afford coverage, then you should purchase coverage and encourage them to purchase coverage. If you access the system and you didn't have coverage, then you defaulted in, and you couldn't afford coverage, then you defaulted into whatever public program it was, whether it was the ACA, whether it was Medicaid, whatever it was, and that you can actually provide coverage with a high deductible catastrophic plan and an HSA or an HRA beneath that would allow for huge savings in the system. So there are ways to do that without putting the government in charge, and that's how I think that we ought to do it. Most countries in the world have put the government in charge, and there. I mean, these are case studies. You don't have to go far to find a case study about what happens, and it's a choice that societies make. One can do that. We could do that. I just believe it would result in decreased innovation, decreased responsiveness to the patient, fewer choices for the patient, decreased quality, and ultimately in poorer access and affordability for the patient. So.
Yeah, I think we've seen some of that come to bear.
Yeah.
Farzine has a question here. It's a long one. I'll read it. Farzine asks, thank you, Dr. Price, for your services. Yes, on behalf of all of us, thank you. You've consistently criticized the ACA for driving up costs and limiting patient choice, given the current ACA marketplace with rising premiums, limited plan options in many counties, and millions dropping out due to affordability. Do you believe that the ACA itself is structurally capable of delivering personalized, affordable care, or do we need to just drop the plunger, blow it up, and start over?
Well, you can't drop the plunger and throw it off and start over completely. But what you can do, I don't think the ACA works. I don't think it can work. I think if patients had a true alternative, and you allowed the system, we allowed patients voluntarily to select the alternatives that were best for them and for their family, for oftentimes lower costs, and again, more responsiveness and higher, I believe, higher quality care oftentimes, then people would gravitate toward that over a period of time. I believe I wouldn't force people to do anything. If people want to stay on the ACA, then have at it. If people want to stay on Kaiser, a closed panel HMO, then have at it. I'm all for choices. But if you're going to be for choices and you're going to allow choices to work, people say the market hasn't worked. Well, we haven't had a market in healthcare in 50 years. So if you're going to say that you allow that choices don't work, then you have to allow people to have choices before you make that conclusion. And so I believe that we ought to open up the market. We ought to free the market up. You ought to, including Medicare and Medicaid. People ought to be able to use Medicare and Medicaid, the whatever the stipend is for that, to purchase the kind of health coverage that they want. We've got folks who are sick, but between 65 and 75 or 80 right now, who are some of the healthiest people in the country.
Mm-hmm.
The last thing that they need is to be shoved into a program that doesn't allow them to see who they want to see or get the kind of care that they want to receive that costs more. But you look at the Medicaid program. The Medicaid program in our nation is ridiculous. Over 2/3 of most Medicaid populations at the state level are healthy moms and kids for whom you could pay cash for every single time that they access the system and save money anytime that they accessed it. And then you've got actually more resources left for the 1/3 of individuals who are either disabled or have kidney disease or are the frequent flyers and the high users and the people who are truly sick on Medicaid. You could bring greater resources to bear to be able to provide a higher level of quality of care for those folks. So there are ways to do it. I wouldn't force anybody into anything. I would open it up and allow people to have choices to be able to select the kind of coverage through wise people like you all that they want for themselves and for their family.
You know, it's interesting. A question popped up in the chat as you were giving that answer, and the person then followed up with saying, well, Dr. Price just answered it, so we'll skip that one. Sean did have a follow-up, and we're going to make this the final question. Sean had a follow-up to his question about ACA, where he asked what's the most efficient way to achieve 100% access. And he was talking about coverage. Should we allow ACA retroactive enrolls like in Medicaid?
Well, you can. Again, I would follow back to the principle of choices. Patients need choices. We need to voluntarily allow patients to get the kind of coverage that they want. You can do that, but that moves people from a system that doesn't work, the ACA, to another system that doesn't work, Medicaid. So I don't know why we would want to do that. So we can get folks covered in these programs that we currently have, but it won't work. It won't solve the challenge that most folks say they want to solve. So my role, my job the way I viewed my job at the state and the federal level as a representative was to help folks understand what the challenges were in healthcare and try to shed some light on the path to some real solutions. Because as I said, most folks, their understanding and appreciation of healthcare is as a patient. That's how they know the system, and that's not a bad way to help try to affect solutions, but it's a relatively uninformed way to try to implement solutions. Again, they're not bad folks. The people up there aren't bad folks. It's not that that they aren't smart. That's just not the world in which they lived. And so I didn't know a whole lot about defense. So when I had a defense question, I'd go to the people who had served or were brilliant about national security. I didn't know a whole lot about transportation when I got in at the state level, and transportation is a huge issue at the state level. So what do? You go talk to the people who have spent their lives in that industry. So, when somebody wants a question answered in the area of appropriate ethical responsiveness in the insurance arena, that's what you all do. And so that, that you want to go to the people that know. I don't think that the Medicaid system allows for people that know to institute the kind of solutions that are necessary.
Well, with your support and those wise words and that amazing perspective, Dr. Price, we're going to continue to act as those advocates. And this is going to wrap up this episode, an outstanding episode of The Voice of the Coalition.
Wonderful to be with y'all. Thank you so much. God bless.
Yeah. Thank you, Tom. This has been amazing.
God bless, Dr. Price.
Truly.
Thank you very much.
Thank you.
Take care, everybody.